Welcome back to our third and final plenary session of the day. We've had a powerful morning of insights, and this next session promises to continue that momentum. Looking ahead to the future of cancer care, while grounded in lived experience and lessons learned, it is my honor now to introduce a speaker whose impact resonates not only in Malaysia, but across the global health landscape. With a background in clinical medicine and a career spanning decades in cancer advocacy, Dr. Saun is a powerful voice championing equitable health systems, civil society leadership, and regional collaboration. Her passion for change and her commitment to leaving no one behind in the cancer care continuum is as inspiring as it is strategic. Please join me in welcoming Dato Dr. Saunthari Somasundaram, President of the National Cancer Society of Malaysia and President-elect of the NCD Alliance.
Good afternoon, everyone. I'm just looking at those two retrobates sitting there and seeing if I can expel them from this meeting, because they'll be laughing at me throughout this whole talk. And now you see this thing has shut down on me. Exactly. Okay, formally now. Good afternoon, everybody. It's lovely to see all of you here. I hope you've been truly fed well, Malaysian style, and had your lunch. Yes? Good. On behalf of the National Cancer Society of Malaysia and the organizing committee, we're really excited, and we're so happy to have so many of you here. Over these 3 days, we've got over 1,000 delegates, and that's absolutely amazing. And why I say that's amazing is that when I started in this space 30 years ago, when I was a medical officer in Hospital Kuala Lumpur, a conference like what we have today, if we were lucky, would have attracted less than 100 people. A conference that included public health, clinicians, academia, lived experience, industry was unheard of. It was sacrilege. You know, every discipline would be outraged that we actually brought people together to discuss cancer. So 30 years on, you know, to see all of you here today, it's amazing. So going back that 30 years, let me start with a simple observation. For a long time, cancer was present, but it was not visible. It was whispered, but not talked about. It was hidden. It was not acknowledged. And many of us know that. The stigma that was associated with cancer was ever present. If it was in our family, our loved ones, we couldn't talk about it. It was all contained in a hidden space. Thus, cancer became non-present. It was still non-present in the global health agendas. It was not mentioned in the Millennium Development Goals. It was seen as too expensive, too complex, and not as urgent as infectious diseases of the time. There was no political will around cancer. Advocacy was fragmented, and so cancer remained invisible. It wasn't present in every sense of the word. The moment it finally gained entry through the NCD door at the global policy stage was in 2011. The first UN high-level meeting on non-communicable diseases recognized cancer as one of the 4 main NCDs, alongside cardiovascular disease, diabetes, and chronic respiratory conditions. Now, cancer was no longer isolated. This political declaration gave cancer the global legitimacy it had long lacked. By aligning with shared risk factors, tobacco use, unhealthy diets, alcohol consumption, and physical inactivity, we moved from a vertical, disease-specific approach to a more horizontal, system-based strategy. And in 2015, the Sustainable Development Goals brought cancer into the center of global health development agenda. As you know, Target 3.4 called for 1/3 reduction in premature mortality from NCDs by 2030, while Target 3.8 established universal health coverage as a global ambition. Cancer was now part of a larger movement for equity, access, and survival. Cancer care then evolved as a continuum. We started talking about integrated cancer care more seriously. Prevention, screening, diagnosis, treatment, palliative support. We began integrating this within hospital settings, horizontally across departments. And with the rising legitimacy, and here I really like to stress legitimacy, because before this, it was considered to be whining voices, ungrateful people. With the rising legitimacy of patient advocacy and patient voices, we realized that cancer care doesn't belong solely in hospitals. It belongs in communities, in homes, in workplaces, in society. And so we continued to move vertically, connecting hospitals with community health services. And today, while cancer may be more visible, the challenge is also larger and deeper. The epidemic of non-communicable diseases is no longer emerging. It is fully upon us. As Dr. Rabin talked about this morning, it is in this room. We know the stats speak for themselves. Globally, about 10 million will die from cancer each year. If we don't do anything about this, there'll be a 40% increase in the cancer burden by 2040. But if we do invest in cancer control, the benefits are incredible. We can talk about $1.3 trillion in productivity and societal gains. And that's not touching about the lives that we save as well. So to cope with this magnitude of this burden, we all look at reforming health systems and debating financing solutions. But for people living with cancer today, the challenges remain deeply personal and really much the same. Whether as a person living with cancer, a caregiver, or someone simply at risk, they face a familiar and painful refrain. I'm sorry, but we don't have this test here. We can't afford it. I'm sorry, we don't have the resources to do this treatment here. I'm sorry, we can't give you this drug. It's too expensive. So what do we do as families, as loved ones of people with cancer? We scurry around looking to beg, borrow. We go to different countries to find medication that are cheaper. And in essence, we destroy our family unit and the future of our children. We've all heard these stories, and many of us have lived these stories. Imagine fighting for your life, only to be told that the greatest obstacle that you feared, which was cancer, is actually not your greatest obstacle. It's the budget. So what do? We increase the health budget. We secure a larger share for cancer, carve out more of the NCD space, make cancer the biggest issue out there. But let me ask you this question. How much is ever enough? Johns Hopkins, we all look to Johns Hopkins, as being where we all want to be. With its $1 billion annual budget, a survey once revealed the top concern of the staff was, we don't have enough budget. So where does it end? Just as cancer isn't only a biology problem, but a societal and access one, the solution isn't only about the budget. So what do we do about it? Are we framing cancer in the right way? Now, after 30 years, we've made cancer visible. Cancer is now present and visible in society. We can talk about it. We're not whispering about it anymore. But is cancer control, we the advocates of cancer control, are we present and visible in society? Or are we still in our little bubble, talking to each other, basically? So what do we need to do? To start, Our thoughts need to shift into the individual, designing care models that are people-centric, not disease-centered, looking beyond the diagnosis and see the full person, their comorbidities, their medications, their context. Can I just ask a simple question here? How many people do you think who are newly diagnosed with cancer have a comorbidity, have something else wrong with them? Just throw out a percentage to me. 10%? 20%? More? 55 to 70% of those who are newly diagnosed with cancer have a comorbidity. Of course, this is age-related. So if you're looking at breast cancer in someone who are in their 30s, you'd have less than 10% who have a comorbidity. But the average age of cancer is over the age of 60. And with those, you have comorbidities. And you're talking about 55 to 70% who have one comorbidity. At least 40% have two comorbidities on top of that cancer, which makes 3 comorbidities that you're battling with. And these, most common being cardiovascular, diabetes, COPD, and mental conditions. And these conditions, as we know, complicate treatment because they overlap. And yet, all of these are being treated in their own silos. Because we treat them all in your silos, as a result, you can have over 30% of a population living with polypharmacy. That's taking at least 5 different medications, as demonstrated in a Danish study. And the more medications they take, the more confused they become, the less compliant they are, and the more vulnerable they grow to falling through the cracks. The cracks could amplify costs and increase the risk of poor outcomes. Our successes are also our downfalls, that we've become so siloed, so specialized in what we do, we don't look at the bigger picture. The polypharmacy example shows what our systems are like today, at least in health. They are not built for complexity, they're built for silos. We must change that. We must design systems that are integrated, clinically, yes, but also emotionally, socially, and economically. This is what the WHO Framework for Meaningful Engagement tells us. Integration only matters when it reflects lived realities, when it supports dignity, when it eliminates stigma, when it connects health with social protection, education, housing, and employment. It sounds very airy-fairy. It sounds very much out there. So what does it look like? Let's bring it down to earth. One case study we often refer to is the WHO's Cervical Cancer Elimination Initiative. In Zambia, Kenya, and South Africa, they integrated HPV screening into HIV clinics. Same visit, same system, same support. The result? Better coverage, fewer dropouts, and a stronger continuum of care. In Malaysia, we're taking a similar approach through our lung health initiative, integrating TB, COPD, and lung cancer screening under one umbrella. Community-level outreach, mobile x-rays, primary care referrals, all coordinated. The results are early but promising. More reach, more equity, less fragmentation. So, in the past and present, we in cancer control have been prima donnas. Let's be honest about it. Cancer takes a lot of the space. It takes a lot of the air when it comes to NCDs. We ask the world to bend to us. We build vertically, and we expect others to climb up. But integrated care is not about pulling people into our space. It is about meeting them in theirs. That means embedding cancer within broader NCD strategies, within universal health coverage reforms, within climate, mental health, food systems, and urban planning. That's how we make cancer present. We must also go where people are, localized, place-based action. That's how we become part of the fabric. So in these next few days, let's try to burst this elite bubble and look beyond care and beyond cancer. The future of cancer control, if we want to get anywhere, is to be in the integrated world we build. So thank you.